button. Okay, now I'm on. Anyway, we.
It has to be green. Yeah, we have new technology, so it needs to be green. And then, if you're not speaking, keep it off, please. Otherwise, there'll be interference.
Okay. Okay, I didn't know she was talking about us. Okay, when she was telling us that. All right. Yeah, these are more fancy than the ones I have in my. Okay, very good. Okay. All right. I guess we've been served. So we'll start with that. All right. I will now call the meeting to order. This is our board meeting for this month. Would you please join in the Pledge of Allegiance? And Commissioner Everstary will lead us. Thank you. Pledge allegiance to the flag
of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Very good. Okay, we'll have roll call. Dr. Summers.
Dr. Summers, present.
Okay. Commissioner Hannigan.
Present.
Okay, very good. And Commissioner Nate Marvin.
Here.
Commissioner Dale.
I'm here.
Commissioner Everstary.
Present.
And Commissioner Purdy. Okay, perhaps not at this moment. I thought she was going to join us. Actually, I thought she was coming. So maybe she had a little highway trouble, or maybe she had to wait for trains like me. Okay, Dr. Summers. Did I? Oh, I already did that. I did you first. I'm sorry. And I'm Commissioner Elliott here also. All right. Have commissioners looked at the agenda? Is there any items that need to be added, at least in an informational setting? Okay, I have a motion to approve the agenda. Do I have a second? I have a motion and a second. All in favor say aye. Aye.
Aye.
All opposed? Motion carries. And we welcome Commissioner Purdy. Okay. November 17th, 2020 Board of Health meeting minutes. Are there any changes to the minutes or corrections to be noted?
Mr. Chairman, I move that we accept them as presented.
Okay. I have a motion. Do I have a second? I have a motion and a second. All in favor say aye. Aye.
Aye.
Okay. Motion carries. Thank you. Okay. As chairman, I asked for this here. Next on the agenda is my comments. So I will read those so I don't get sidetracked. So, dear members of the public, whether the few in personal attendance or via electronic means, as chairman of the Southwest District Health Board, I have the opportunity to ask for an added agendized item, which I have done at this time. For this time. Actually, any board member can ask for an addition of an item, as some or most have done in the past. I specifically ask for this time in order to vent or rant about certain, if not many, of the emails that I receive. I receive 40 to 70 per day. Most of them, I would say at least half of them, are directed in the wrong spot because they have nothing to do with Southwest Health District, only Central Health District. But many of these state that do come here state that Southwest Health District have violated the open meeting laws by, number one, not allowing more than 10 persons in a public meeting. It is my understanding, and that of our county prosecuting attorneys, that the Stay Healthy order of 10-person limit does apply to public meetings. However, the governing body of a public entity does retain the discretion to allow for more than 10 persons to attend a meeting if and only if certain rules are followed to protect the public health and ensure the orderly conduct of the meeting. That has been interpreted to include, but not limited to, proper distancing as described by CDC guidelines. Also, if not desired by the governing body, a physical location for the meeting must be provided with one member at least of the governing body or the director or the chief member of the governing body or chief administrative officer, is physically present as per open meeting law manual. Page 15 and 16, question number 25, specifically describes this. In that scenario, the political subdivision should, not mandated, but should, ensure the meeting is available remotely to the public via phone or internet, which we have done since the very day we have had capability to do so. Number two, this is not a public hearing. I emphasize, not a public hearing. This is a board meeting only. Public hearings are required to allow input. Board meetings do not. A board meeting may allow public testimony in person from the folks here, as this board has done in the past. This has been something the board has felt proper in order to see if there's information, such as personal experiences, different or additional information to the electronic or written correspondence that we receive, each of us receive daily. It has allowed us to personally see the emotional consequences of this COVID-19 outbreak, the consequences of certain mandates, requirements, etc. Up until recently, this allowance has been beneficial in various ways. Number one, it's allowed a venue for the folks to personally share all these passionate feelings that they have to an actual in-person board. It's a chance to vent frustrations, fears, hopes, etc., and know that at least somebody has heard them. I personally open every email I get. I read every one that is not a form letter. I'll read the first form letter, but and I note, but the rest that come up, the rest that come up that's the same form letter, I note the fact that at least they've had the ability or desire to state something, but not to take the time or energy to really share anything personally that's not stated in that email, in that form letter. Some of these personally written emails are very long. If they were printed out on a typed page, they'd be 2 or 3 or 4 pages, some of them. It takes me at least 2 hours a day to read all my emails. And like I said, I open every one of them, and I read every one that's not a form letter. As I said, up till the last meeting, folks were normally respectful of our time and the time of the other folks who wished to testify or give information. Last meeting, however, a certain black hat wearing individual broke with respect and common courtesy and verbally, and in my mind, viciously made personal attacks on a board member. I take full responsibility for not immediately stopping that. I thought that fellow would stop after he made his point, but he did not. He continued on, and I should have stopped it. I apologize for not doing that. However, that was a straw that broke the camel's back in my mind. His opinion was not concerning to me or to the other members of the board, but the jerkazoid personal attacks were. With that burning in my mind for at least the next week, I, as chair, I took it upon myself, so if people want to gripe at me, that's fine. I asked our director to remove the public input from the agenda, at least temporarily. As stated before, a board meeting may allow or solicit input from the public, but it is not required to do so. As far as, I stated earlier that this was something we felt was the right thing to do until it was abused. And that privilege is abused, and I guess sometimes when you have little kids, you have to take away that privilege for a while for them to behave. But that is not the purpose of a board meeting. So, in that light, you blame me as chair for taking away this privilege. Not Nikki, not anybody else. That needs to go to me. And most importantly, the black hat individual for this removal of public input on our agenda, at least at this time. Basically, that is my statement. I think that we have tried to do the right thing, and at the last board meeting, I felt that was severely abused. However, I will also state that in the, I don't know how many thousands of emails I've had, that there really hasn't been anything new other than the venting and the personal. I get that. We all get that. Many of the emails say I have no clue as to the angst or whatever that goes on with all the requirements and the restrictions that go on today. I will tell you in my, I don't know how far you want to call immediate family, but my sons, daughter, and grandchildren, I've had 7 folks that's had COVID. My wife's mother, my mother-in-law, 98 years old, in a nursing home. We have not had the ability to, other than from a distance, to visit her, talk with her. I've had other members a little farther away in my family that's been hospitalized for, one or two of them actually, for COVID. They weren't hospitalized. They got COVID, but they never went anywhere except the hospital. But we all, as members of the board, I think I can probably speak for everybody, know people, have family members, etc. So we do know what's going on. I get a little emotional when I think about a 17-year-old boy, a good friend of mine, that committed suicide here recently because he just couldn't handle it. I do know these things. I think all the members here do know that. We're trying to do the best we can, but at the same time, this is a state-run, state-directed entity, and we have to follow the rules and regulations that we have been given by state statute. And with that, I've taken more than my amount of time. I will shut up. Yes, go ahead, Kelly.
I'd like to add to that. None of us here want to do anything that is contrary to what our citizens wish us to do. But the very fact is we're under court order on a lot of this stuff also. So if you want to get mad, go to the Supreme Court of the state of Idaho, because a lot of these things that we're under are under their direction. So that's a court order. I mean, we have no choice. If we try to break that, we can actually be arrested for doing those things. So we got to be very careful. We're just following what we are told to do. Whether we agree with it personally or not doesn't matter. We're here to represent the citizens, and so to do that, if we're not following the law, then we can't be here to represent the citizens. So we need to do that. That's part of what we're required to do. So let us do our job. I mean, that's plain and simple. We don't need to be abused, attacked, or whatever, because most of us feel, that maybe this isn't the greatest thing since sliced cheese, but, it is real. I mean, I've had 4 family members that have been positive for COVID. I had to get tested last week because I was at a Thanksgiving where my daughter-in-law's father and mother both came back positive. So, and we were there all day with them. I had to go through the complete isolation, quarantine, and then get tested to make sure that I was clear. That's just part of what we need to do. So, just just let us do our job, rather than, it just irritates me, because I'm very conservative, and it just irritates me to see I just don't want to be a part of that. Thank you.
Mr. Chair.
Thank you, Mr. Chairman. Commissioner Elliott, I really appreciate those words that you communicated with us there. And I want to just set a couple things straight here. I've received probably the same number of emails you have, and like you, I open them all and I read all the ones that are not form letters. I'm grateful you put that out there, because we've been inundated with a certain form letter. Mm-hmm. And I've tried to actually respond to nearly all of those people in some form. And I would just want to straighten the record for one of the things that I've seen multiple times on emails is that they know that I, Tom Dale, am getting coerced and pressured to cave in and do stuff. I don't know if you guys are getting this.
Yeah, I
okay.
get the same.
And I just want to put it on the public record that I have not received any pressure from Central District Health or any of their commissioners or any of their board members to do anything that is beyond what I feel is right for Canyon County and for District 3 of the health district. So that information is spurious, it's false information, and I just want to put it on the record that personally, I am not feeling any pressure from those organizations to do something contrary to what we're already doing. So thank you, I appreciate that.
Okay, thanks. Actually, that kind of leads right into our next section of open discussion. So let's just go into that, and that way we have gone in or followed our agenda. But yeah, we do have some time set aside now for open discussion from board members. And
Mr. Chair?
Excuse me?
Yes,
go ahead.
This is Commissioner Hannigan, and I just wanted to say I probably don't have the numbers that you have. I fly a little under the radar. But yes, I've had lots of emails and I've had some personal phone calls. And one sticks out in my mind is after she got done dressing me down for not doing my job, I had the opportunity to say, do you understand what traditionally the health board is tasked with doing? And we had a long conversation about WIC, about vaccinations, about education, about all of the things that the health board still does before the COVID fiasco hit us. And that then the COVID is on top of all of those things that we're continuing to do. And by the end of the conversation, she had a different perspective than when she first called. And it's too bad that we can't get that type of education out there to some of these people who are just a little blind to what our traditional role is. And I just felt it was educational on her part. It helped me feel better about some of the stuff that I've been faced with. So just wanted to share.
Okay, thank you. Commissioner Purdy, you were asking?
Yes, and I appreciate what you were saying and your reasoning for doing this, but I would say that it looks to me like, and from the emails I got, it's been counterproductive as far as that. We would probably be better off if we had them in here than sitting and listening and fighting. For the most part, we had great comments and people were incredibly respectful. So, and as a commissioner, sometimes we take heat. and that's just the job, that's the way it is, and, I don't really mind that. In fact, I would prefer to hear people's opinions than to have them feel like they're shut out in any way. Those are our constituents, and Dr. Summers, I'm sorry that you felt like you were attacked, that's, you know, you want to be a member of this board, you're probably going to take the heat just like the rest of us are. So, anyway, that's my comment. I just don't think that this worked out very well for us in the end, and plus I don't, of course, you guys know I don't agree with most of these, recommendations anyway. These people are losing their businesses. What was supposed to go on 2 weeks is continuing month after month after month after month. Our governor has spent $8.1 billion plus. If we should have done different things if we needed to do them towards the hospitals. I've got the St. Luke's numbers right here on every single one. Another single one of them is excessive. I think 23% is the highest ICU rate I have in one of these hospitals, and I believe that would be the Boyd Field Meridian. So I'm just a little perplexed as to why we continue to push people over the edge and continue to allow them to do their very best, and then they're still losing everything. Their suicides, we're just not paying attention to anything else but this, and we need to go back to normal because we can.
Okay. I want to state for the record, Vicki, that Dr. Summers did not contact me. I did not contact him. This was a personal thought of mine.
I actually assumed that.
And I think he handled the situation very well at that meeting. He did not come to me and ask me any of this. This is me. This is me, and that guy was just out of line. And I think I stated to start with that mostly, yes, up until that time, most folks were fairly respectful, if I can speak. Because I woke up at 3 o'clock this morning and couldn't go back to sleep, and I'm ready for a nap. This has been weighing on my mind heavily for the last little while. No, this isn't anything that any of us put in for. It is what it is. I'm sure all of us from different experiences have different thoughts on what is correct. I would like to state, as Tom brought up, that, or Kelly or both, I'm not sure, it kind of all blended here. But, as chairman, I probably, have more thought towards the representation of the entire district. However, personally, as Jim County Commissioner, I have a great, perhaps, I'm not sure, it's hard to delineate it, but perhaps a greater responsibility to those folks that voted for me to try to represent them and their wishes. As Kelly said, trying to put aside our personal beliefs. I think we have, I believe that's my responsibility, is to represent the majority of those folks and what they want. So far, I think I've done that. I guess time will tell. But anyway, yes, Doctor.
Dr. Summers, and I have a number of comments, and I've been wanting to say this for the last couple of meetings, but it seems like we've gone so long that I didn't want to prolong the pain. So our mission statement is to promote health and wellness of those who live, work, and play in Southwest Idaho. That's our guiding light. That is the rails, the road we are on. Everything we do has to be congruent with that mission statement. And if it isn't, then we need to reassess, why are we doing that? Why are we spending the time? Why are we spending the resources to do that? If you really look at what we do, prevention is the biggest thing that we do. 2 months ago, we talked about septic systems and inspections. Why? Clean water. But wait a minute, it's my property. Why can't I put the system on that I want? Public safety. I don't want to drive the speed limit. I don't want to wear a seatbelt. I want to drink a beer when I drive. Why can't I do that? Why are there laws? Public safety. So why not a mask mandate for COVID and public safety? We know masks help, as do other measures. There are multiple studies from reliable institutions and journals stating so. During the week of December 3rd through 9th, I calculated the daily rates of COVID for Idaho, Oregon, and Washington. Both Oregon and Washington have mask mandates. Idaho has 2.5 times the daily rate that Washington does, and 2.8 times that of Oregon per population. In June, Kansas, the governor adopted a mask mandate, but there was a provision that the counties could opt in or out. Of the 20 counties that opted in, their COVID rates dropped. Of the 81 counties who opted out, their rates continue to climb. Why is 80 counties' COVID rate lower than ours, adjusted for population? It certainly isn't social distancing. The question is, how much bang do we get for our buck with the mask mandate? I certainly worry that we may be too late. It is so prevalent that we may be too late. This should have been done 4 months ago. Community education is not working, so why do we continue doing the same thing? Einstein's famous quote, doing the same thing over and over and expecting a different result, is the definition of insanity. So do we do something different or sweep it under the rug, or do we need to change our mission statement? Personally, I think we need a mask mandate. I believe there's a bigger issue than Region 3, though, and I think Region 3 and 4 should be on the same page, and I personally believe that this should come from the governor. Again, maybe we are too late for meaningful impact. I believe it's a sad statement when our school boards are more proactive about COVID than our state, local governments, and our health districts. Why do people run for office? I believe it is to serve and leave a mark on the respective community. In regards to COVID, I believe this is a scar. The one thing the press does get wrong is they keep referring to healthcare facilities and workers as the front line. They are not, we are, by wearing masks, social distancing, etc. Healthcare workers and facilities are the last line of defense, and they are getting close to the breaking point. They are heroes. Every 30 seconds, someone dies of COVID in the U.S. During this 3-hour meeting, 360 people in America will have died. Every day, a town the size of Homedale disappears. You can take my statements and my numbers and question them. Several months ago, I asked Dr. Roscoe to interrupt me and this board if he hears me give any information that he believes is false. You can question my statements, but don't question my motives, because it's the same as our mission statement.
Very good, thank you, sir. Anyone else? Yes.
This is Tom Dale speaking, and I appreciate Dr. Summers comes from the medical profession, and I really respect his opinion. I have a different opinion, and that's okay. We all have our own opinions, that's fine. I follow very carefully. I get the Idaho Press every day, and every day they have a report on new cases and deaths and all that kind of stuff. Oh, sorry.
All right, this is Tom Dale. I'm sorry I didn't have my microphone on, so I'll start over. Anyway, every day I read in the Idaho Press the numbers that are there. It kind of, this will kind of age me a little bit, but I actually, it throws me back to the days of the Vietnam War. And every day in that Vietnam War coverage, we would see the death count, well, they called it the body count back then. And it just keeps continually in front of you, and it's I don't know, I guess there's some value in it, but it's not the only thing happening in the world. And I think we need to acknowledge that. Over the last several weeks, and I haven't done a mathematical computation on this, but I've followed these numbers between Ada County and Canyon County particularly closely to see what difference we should see there. And over the last several days, Ada County has had nearly 3 times the number of new cases per day that Canyon County has. Today's report, Ada County has 376 new. That's from yesterday, I'm sure, because they don't know about today yet. And Canyon County, 143. That's still more than double of what Canyon County has.
That's not.
And so let me just finish.
According to my non-mathematical computation and my mathematically challenged brain at times, I would expect that Ada County would have twice as many cases every day as Canyon County because they've got about twice the population. That doesn't take into consideration that they have a mask mandate over there on certain areas, and we don't. So it tells me a couple of possibilities are presented here. And the one that I choose to believe is that in Canyon County, our numbers are kind of tracking along with what Ada County is doing because people have chosen to take on their own responsibility to wear a mask when they're in a store and to do these kind of things. We see nearly all of the stores that I go into and Caldwell and Nampa require you to wear a mask. And they ask you to do that, and the private business is taking that on themselves. And I just want to believe that people are trying to do the right thing for themselves and for their families and for their friends, and they're doing it without a mandate coming down from any of the cities or this body here. And that's just my comment. It is, and I understand what you're saying, Doctor, but the numbers show every day, and right now, Ada County and Canyon County are running population-wise, percentage-wise, about what they should be.
Dr. Epperly, this is Dr. Summers. Dr. Epperly sent me a report, Ada County versus Canyon County, and I guess I would argue that point. We'll go 11-14 positive in Ada County was 80. I lost it. 93.56, so that would be close to double. But if you look, Ada County is twice the population, and they're lower. If you look at their rates.
Well, and again, I'll read some statistics going back here. December 7th, Ada County new cases 306, Canyon County 92. December 8th, Ada County 547 new cases, Canyon County 266. December 9th, Ada County new cases 714, Canyon County 204. December 10th, Ada County 563, Canyon County 278. December 11th. That just kind of shows you that it's tracking along there. There are anomalies along the way, but basically over the last couple of months as I've been tracking this, it is tracking that Canyon County has about half the cases that Ada County does, which would be appropriate based on the population. And I choose to believe that Canyon County residents are taking it upon themselves to wear masks and wash their hands, stay home if they're sick, and do all that kind of stuff on their own responsibility. That's how I choose to think of it.
And I would argue that goes to my point that Region 3 and Region 4 need to be on the same page. The district between Region 3 and Region 4 is arbitrary. And, all you have to do is get on the freeway at 7 in the morning and you can see it. And I will argue that the difference between Region 4 and Region 5 is a big leap. There is a barrier there. But that's why I do believe that this needs to be a conjoined Region 3 and Region 4 event.
Okay.
Mr. Chairman, I concur with yours. I have all the numbers here as well, and they're actually divided out by hospital. So it does go along with exactly what you said. And I don't have as much faith in masks because I know that they cause other problems. And part of the problem I have with it is everybody wants everybody to wear a mask, but nobody considers the issues that some people have that they shouldn't be wearing masks, like our veterans with PTSD who should not ever be asked to put a mask on, like people with asthma, like people with heart conditions. I mentioned the OSHA requirements that if you have a heart condition, you should not be wearing a mask. And if your employer requires you to wear one, then they're required to do a health check to make sure that you can tolerate a mask. So there's several things. There's a lot of issues being caused with masks. As Kelly mentioned last month, we're talking about staph, bacterial pneumonia. There are things that can exacerbate that, and probably more so this time of year with the mask and as we breathe in and out, the CO2 levels that we breathe in and out. But the one thing I did want to mention that hopefully will have some credibility is Dr. Livingston was on KIDO December 3rd at 9 a.m. and he talked for about 20 minutes. And he said he had visited every single ICU unit in the state and not one of them was overrun. He said that they had the numbers and they had the capacity and the ability to create more ICU beds if they needed to, but from the numbers that I have here, the COVID numbers are quite less as far as maybe 10, 11%. There was, I think, one day where it was 24% in one of the hospitals in Ada County. But overall, the hospitals have plenty of beds and plenty of room, and there has been staff that has been furloughed from St. Luke's. I haven't heard anything from St. Al's, which I find interesting, and I had a couple people tell me that St. Al's is much easier to deal with on this as far as if you go in there and you have a health condition, they're not forcing you to put a mask on before you get in the hospital. So anyway, I think you're right, Commissioner Dale. I've gone into business in Canyon County. I stay out of Ada County if I possibly can, and the businesses require you to wear a mask. A lot of times, you know, if they're insistent on it, some people just won't go in. I'm one of those, and I'm not rude or anything like that. I'm not going to put a mask on and end up with, you know, a bad headache, which is what happened. So, and I don't think anybody seems to have any consideration for any of that. We're all just supposed to wear a mask, and we're all the same, and that's just the way it is. But there are things that we can do to prevent COVID, and everybody seems to want to just shovel them on the table. If HCQ works in other countries, it should work in the United States of America as well. So, anyway, I do appreciate your comments, and that's I won't say anything else.
This is Dr. Summers. Part of the problem is I'm asthmatic and I do just fine with the mask. You know, it's amazing how these nurses can work 16 and 18 hours and wear a mask continually and they're still alive. I will also tell you that the numbers can be changed, and one of the problems is I can have a 300-bed hospital, but if I only have enough nurses, respiratory therapists, pharmacists, physical therapists, etc., to work for 100 beds, I've got a 100-bed hospital, and that's all I can do. The other part of it is that 100-bed hospital now has OB, it has postpartum, it has pediatrics, it has a surgical floor. All of that consumes available space.
I think we all know that. We've all heard that staffing is one of the largest drawbacks right now as far as, you know, capacity. I will say, though, on a personal note, you know, I'm glad that you can wear a mask and be asthmatic. My brother is also, at least as a child, was very asthmatic. He's a dentist. He wears a mask all the time. Okay, but my wife's had pneumonia twice. Here a while ago, she went into a store that required a mask, and trying to be compliant, she threw a mask on, went and did her shopping. In the checkout line, she passed out. She cannot wear a mask very long because of her reduced ability, I guess, for oxygen. You know, she gets a little bit too much CO2 and down she goes. And she's tried it one other time and not quite, but, you know, I mean, she had to sit down immediately or fall on the floor again. And so there are people. I mean, it's not everybody. I know that, but to Commissioner Purdy's point, there are people that I don't think are being looked at. And, you know, I mean, if she went into a store and didn't have the mask on, man, would I mean, she tries to be compliant with a private business. And, you know, if we go in, it's a real short time, or I go in and get stuff, and I mean, I could wear a mask all day long. I don't like it, but I can, because I don't have a problem. But there are people that do, and I wished at least that part would be looked at somehow, and then those people not totally, you know, disregarded or looked at as a a lowlife. Yes, Commissioner.
And Brian, thank you. And I would say in the state of Washington, where my brother lives up at, yeah, it's on. And the state of Washington has had a mask mandate for months. But up there, the law states very clearly that if you have a medical condition or some other psychological thing that prohibits you from wearing a mask, you don't need to do that. And secondarily, in the state of Washington, a business, grocery store, whatever it is, cannot ask you what your medical condition is. If you tell a person there that, I really can't wear a mask, it's just not possible, they can't not ask you why. And a lot of the businesses here in Canyon County, Caldwell and Nampa, that's the only places I go to do business, that's where most of the stores are. On their notices, if they require a mask to enter, I've seen on several of them, not all of them, but on several of them, there is that caveat that if you have a medical condition, you don't need to wear a mask. And so that can be done. It's being done in other states, and I'm not advocating for mask mandates. I think I've made that clear. But there are exceptions. I will back 100% any private businesses who says they want to mandate masks in their business. I will back that 100% because that's their private property. They have the right to do that. And if a person has a medical condition, most of them are understanding of that and will allow that to happen.
Okay, thank you. I also definitely would back the private property rights 100%. Commissioner Hannigan, did you have anything you wanted to throw in, or? Commissioner Marvin?
Thanks, Mr. Chairman. I've been listening to everybody speak, and a lot of good comments, a lot of information. I too watched the difference between Ada County and Canyon County, where Ada County has a mask mandate. I can't see much difference in the numbers where it's helping. Maybe there's more to the story than what I'm seeing on the fact sheets, but and I too support any of the businesses in our county that want to have mask mandates. I wear a mask in there if they're requiring it. It's just a tough situation that we're in, and I've had, like the rest of you, email after email not to mandate masks. And we've all been asked to voluntarily wear a mask by, the health department, the governor, Idaho One, everything we see on TV, wear your mask. So I think that we're doing everything we need to do without doing a mandate on masks. And I'll leave it at that because I don't want to keep repeating everything that other people have already said.
Okay. Thank you, Nate. Appreciate that. Commissioner Hannigan, did you have anything you'd like to add?
I can only say that I would urge that we make sure that the public doesn't lose sight of our core missions of public health. And no, I'm not a mandate advocate unless we've got enforcement ability, and I don't see that happening.
Okay, thank you. Yes, Commissioner Dale?
I just want to add this, that there's nobody, well, I don't know anybody personally who's I know people in my family who've had this, and I know other people whose family members have had COVID. A 35-year-old son of my college roommate was in the hospital for 3 weeks, intensive care. Healthy young man, no other physical problems. This is a real disease. It is not a made-up story. There's no conspiracy going on to hoist a hoax on people. This thing is out there, and it affects people differently, and nobody who's had it says they would wish this on anybody. And so we need to understand that it's serious, and we all take it seriously. We just have maybe some different opinions on what should be mandated and what should. And so anyway, I just wanted to put that out there, that this is, I believe this is real. I know it's real, and we acknowledge that here.
I believe, maybe I speak for everybody, that we believe it's real. I don't know if I do or not. I know, like I said, I've had enough family members, both close and a little bit farther away, that's had it. I mean, it's a real disease. We know that. I think part of my direction as to what Dr. Summers said was the health, but I don't think it's just a body count or just a serious 3-week stay in the hospital like, the one person you're talking about. I think it has to be an overall look at all the health, mental as well as physical, and the cost of what it's doing and has done, especially to our kids. I think our kids have been screwed. That may not be the right word, politically correct, but I'm not a very politically correct person. But they've been hammered, and I really am seriously concerned about their development in the future, both socially. I mean, I throw this all in the mix. It's not just one thing that determines, but I try to look at all the repercussions, the things that go along with the mandates and the restrictions that we have everywhere right now. And personally, I also am not in favor of a mask mandate. Part of the reason that we wanted to have this discussion today, this open discussion, was to find out, I guess, I wanted to double check everybody's feelings on this to see whether there was any reason to have a special meeting for a mask mandate vote. At the present time, I'm not seeing that. From what I've heard today, I don't think it's a viable reason to have that. I just don't think it's going to pass at all unless there's change. And if I'm wrong, please correct me. But from what I've heard, I don't think there's very much push or direction for the majority of the board to pass a mask mandate. So unless I'm incorrect, I think that's a moot point at this time. That may change, with new information or science or whatever. That may change, and I'm hoping that everybody on the board is open to new information or scientific proof that comes that would outweigh the other things, at least that I look at, as far as some of the detriments to those areas or to those mandates. Okay, is there anything else that anybody would like to bring up on this discussion? If not, we will move to our next, which we have passed that time just barely. Our COVID-19 situation update from Jamie. Or did I hear we're okay to go ahead and move on? All right, very good. All right then, Jamie, I guess you are up.
Well, good morning. Can you hear me okay?
Yes, we can.
Okay. This is Jamie Annenson. I am the incident commander for the Southwest District Health COVID-19 response. And I have officially moved into this position as a full-time incident commander while we work through our staffing transition. And I'm just going to give you a very brief update on some of our recent activities. And
Jamie,
we continue
can you speak up?
to... Okay,
Yep.
Can you hear me? Is that better?
It's a little better. I'll turn up the volume on our end, too.
Okay. We continue to operationalize the response.
You're
that is
fading away
ongoing.
again. So not sure why, whether it's on your end or our end, but you are hard to hear.
Okay, Ashley, how am I doing? I'm on my phone.
Hi, Jamie. You sound great through Zoom. I'm not sure if it's just the
A little
audio
better. Well, no, that was somebody else speaking.
Okay, let me try again. Is that better?
That's better,
I think the audio issue is in the room.
Please mute your mic. Please, sorry about that.
Do you want me to try? Is that any better? Okay, so we continue to operationalize the response. That's something that we've talked about before. We are wanting to operationalize this within the organization. We have completed our staff training on the Incident Command Structure, or ICS training. We continue to recruit for a COVID-19 program manager to oversee the day-to-day operations in that work. We as a team are working closely with Eugene and Lori of High Focus to help us meet the demands of the work and also to strategize for how we can operationalize our COVID-19 response at Southwest District Health. One of our biggest challenges continues to be staffing to be able to keep up with the workload. We have encountered challenges with recruiting some positions like registered nurses, medical assistants, and bilingual staff. So we are continuing to recruit for additional COVID-19 investigators and liaisons to help meet that demand. We also have some office space limitations and have attempted to implement a hybrid model of in-person and remote work to make room for the additional staff that are working on our COVID-19 response. Additionally, we have 13 Idaho National Guard members helping us manage our investigations and testing demands, and we're expecting another 6 Idaho National Guard members next week to help us expand testing and keep up with our contact tracing and investigations. We have now added Saturday testing to the schedule, and we're consistently full with our scheduling of tests. We're doing right now 20 tests per day with some, we do some walk-ins as we can handle that, and we're consistently full. We are seeing waves of demand for testing. So the waves are appearing to come in 2-week cycles. Last week was very busy. We averaged 80 phone calls per day. Our call volume has decreased some this week, but we are consistently filling our testing schedule each day. Our staff have worked nearly 40,000 hours since the start of the response in March of 2020. We're continually working on communications and educating the public. We now have a full-time public information officer working on COVID-19 media and public relations and education to the public. Our logistics team is actively distributing PPE, personal protective equipment, sanitizing solution, and test kits to community partners. You know, as a result of being in this response since March 15th of 2020, we're continually faced with employee fatigue due to the length and scope of the response. We have increased demand to complete our regular job duties and serve the members of our communities and also engage in the COVID-19 response. So like many employers, we are experiencing employee illness due to COVID-19 exposure in the community. And our employee wellness component has been really important to managing the number of our employees who are out ill or experiencing an exposure. Our team is collaborating with our healthcare partners and involved on daily phone calls to receive situational updates. We continue to monitor our healthcare system availability very closely. Our hospital systems are stressed and getting by on a day-to-day basis. Our partners tell us that their COVID patients are sick and resource intensive, which results in more staffing demand to care for these patients. They are also fatigued after putting in long hours and working day to day. to care for patients. And we are continuing to be very concerned with the data that we see coming from the hospitals about staffing and ICU bed availability. Unfortunately, our case numbers are not going in the right direction. Our hospitals are reporting this week that they continue to show many resource limitations and stress. We are consistently seeing widespread transmission and lots of unknown sources of exposure. And even with the addition of our Idaho National Guard assistance, we are continuing to have to prioritize our investigations as we just cannot investigate every case. We just can't keep up. That's all I have for my report. I will leave the vaccine update and the data update to Ricky and Rachel, who are also on the agenda.
Mr. Chair, this is Ricky Bowman. Would you like me to start, or do you want to comment for questions for Jamie?
Well, my mic was not on, so when I asked for any comments, I don't know if anybody heard me. Okay, well, we have some that's far away, 70, 80 miles from here almost. Anyway, okay. If not, then, yes, please, go ahead, Ricky.
Thank you, Mr. Chair. Good morning, Board of Health. I'm going to give you a vaccine update. I have on the phone with me Carol Julius, our Division Administrator with Clinic Services, and Dr. Clay Roscoe, who will help support. Dr. Clay Roscoe will answer any of those specific medical questions around the vaccine. I will speak on our coordination efforts and our planning that we've done. I must preface this by saying that this is moving at such a fast pace with things changing that I wouldn't be surprised if some information that I tell you now may change within, the upcoming hours or days. And so just please understand the fluid nature of the vaccine planning and the information that we're getting from health and welfare and from other partners, but it is just moving at a very, very fast pace. I will say that, as you guys have probably seen on the national news, we do have emergency use authorization approved for the Pfizer vaccine, and that vaccine is being shipped into Idaho this week. Our allotment that we receive is going to be approximately 2,000 doses that are going to be allocated to the Tier 1A group, which is those hospital workers, frontline healthcare staff that are providing inpatient care, long-term care residents, and staff in those facilities. And we'll talk more about the specific breakdown if we have any questions on that. I will say that in getting the vaccine out, our main focus within our internal planning team who meet daily is just really getting the vaccine in to individuals and providers as soon as we can, so there is no wastage or any excess. The Pfizer vaccine has special storage and handling components to it that make it a little more detailed within the planning to do the logistics and coordination of that vaccine. I will say that we are in constant communication with all of our healthcare partners and providing the distribution plans to them and working through them. We still have coordination calls that we would need to be on today and tomorrow to firm up plans, but we are in constant communication and coordination with them. I will say the majority of all of our healthcare providers are enrolled through the DHW vaccination program, which will allow them to store and administer the vaccine. So they will be able to keep that location if they meet those requirements. I want to stop right now because, like I said, there's a lot to unpack within this, but just maybe ask any questions specifically around Pfizer and Moderna vaccine that you guys are seeing that Carol, Dr. Roscoe, and I can have, and then kind of move forward about how we plan on rolling that out to our healthcare providers.
Yeah, this is Tom Dale. Just a quick question, Ricky. Yesterday? No, what's today? Tuesday? Yeah, yesterday. yesterday on Monday, I had the opportunity to hear from Director Jeppesen. He's from Department of Health and Welfare, right? And anyway, he was talking about the distribution of the vaccine, and he was indicating that based on the priority list that we see, the general population can expect to see availability probably early summer. Does that fit with what your timeline talks about?
Yes, Commissioner Dell, we've been hearing from our DHW partners that spring-summer time frame.
And then do you want to talk a little bit about the timeline for the Moderna vaccine?
Yes, and so we just received an email from Health and Welfare to provide them our numbers of allocation of that vaccine. We are slated to receive 3,900 doses of that vaccine, and it should be coming in next week. They actually are going to follow that same process with the Pfizer vaccine to get the EUA, get it approved, and then the Idaho COVID-19 Vaccine Advisory Committee will get that out to us as far as information on those priority groups that roll. But we have been told this morning that expecting that vaccine next week.
Thank you.
Carol, Dr. Rothko, is there anything to add at this point that I may have missed that you would like to discuss with the board?
Ricky, this is Carol. I don't have anything else to add. Our team is working together with nursing staff, clinic services, and PHP to take care of our community needs.
Yeah, hi, Ricky. This is Clay Roscoe. Just also want to share with the board that Ricky and I and the rest of the team are working very diligently to identify independent practices in PHD 3. We want to make sure that these smaller healthcare provider groups with or without physicians, so also including advanced practice PAs and NPs who staff clinics are also included in the list for evaluation for the laid out tiers for vaccination with the Pfizer and the Moderna vaccines. We continue to gather information on that front. I also wanted to just share with everyone that the Moderna vaccine does not have the same temperature requirements as the Pfizer. It actually can be stored at regular freezer temperatures as well as a period under refrigeration. So we do anticipate that there will be a bit less of a logistical challenge that we will think through and complete as we distribute the Pfizer vaccine first.
Thank you, Dr. Roscoe, for that. And then something else that I wanted to add is that we are working with the state to be really closely in the loop on when the National Pharmacy program is going to be enrolled. My understanding that program has already been activated from our phone call this morning, and so they will be receiving shipments of the Pfizer vaccine. That pharmacy program is a partnership with the CDC in providing the pharmacies, those large retailers, that vaccine to provide vaccinations to long-term care residents and staff on site. And so we're going to be working within those pharmacies and understanding where those vaccines are going out with our long-term care facility partners. We do have several long-term care facilities that have not enrolled in that program that we would be working with them independently to offer up vaccine and to support them in that way. So I did want to make sure that you guys were aware of that as well. So from our call this morning and what we were told is that the focus, at least for what we know now, is that the shipments were coming in December. We'll have more information in January about the subsequent shipments that are coming and then the populations in the tier groups. But within those tier groups, we're just going to be working right now closely with our hospital frontline healthcare partners, and it's been very good. We have had lots of good conversations and coordination with them, with our partners. And so I'm just grateful for all that they are doing to help and support and coordinate and provide the vaccine to those individuals that would like it. We also, my planner, TJ Wilson, is working with our emergency managers to identify the first responders and be able to provide support for vaccine that way. So it's coordinating those efforts with our emergency managers to provide the vaccine to our emergency responders when that becomes available. Again, as far as just the way that things change in guidance, it just moves very fast, and I want to be able to share as much information as I can, but knowing that things just change so rapidly. But we are meeting every day, really honed in on that coordination piece, at least for these first couple of shipments, and getting the vaccine to those healthcare providers so they can administer those vaccines. Any questions?
Ricky, this is Commissioner Marvin. Did you say there was 2,000 doses coming in of the Pfizer?
Yes, sir. Our first shipment that we receive, they come in 2 tray shipments in 1 shipping container. Each tray holds 975 doses. And so we'll receive that shipping container, we were told, anywhere between Thursday and Friday, but approximately 2,000 doses.
Okay. And is that for the whole state of Idaho, or just pay it?
That's for our health jurisdiction, so our 6-county region.
Okay. Thank you.
Yes, sir. Yeah, well, Mr. Chair, that's all that we have at the moment, unless there's any other questions.
Ricky, can you hear me now?
Yes, sir.
Okay, yeah, we had a problem there for a while. Here in our room, nothing was going through. Yeah, I had a question as to, are the outlie areas, are those folks have to come to a local distribution, a local pod here? Or like, for example, in Commissioner Purdy's area, you're a ways away. Are those folks, do they have to come down here? How are they going to be served?
Yes, that's a great question. So we do have a call this afternoon to really flesh out those distribution details. We do want to be able to accommodate those providers where distance may be an issue, so it would be kind of those one-off discussions. But with the shipping and distribution piece and how that works and the temperature control method, having individuals actually come to the point where the vaccine is the preferred recommended method, and then working out any logistic details. If that isn't feasible, then we work with those on a one-on-one basis. But ideally, it's coming to that one distribution point and then going out from there. I mean, Dr. Roscoe, I don't know so much about the temperature control methods, if you heard any more of the monitoring, but within that shipping container, we were told in our state call today that, we do have to record and monitor those temperatures, and even making sure those containers can read those temperatures accurately. So, Mr. Chair, does that help answer your question?
A little bit. My concern is, some of these smaller outlying counties don't have a ton of people that they can, if they send everybody that needs to go to a point of distribution, they don't have anybody to take care of folks up there if they're needed. That puts quite a, possible stress on them. I mean, if they're lucky, nobody will need anything till they get back there, but I don't think they can go with, and don't have anybody to take care of problems. That's all.
Yeah.
And it is my
recognize.
Okay, it was my understanding too when you were talking about, I thought that, what I had read, and maybe I am wrong, but those shipping containers have, built-in monitors, temperature monitors and recorders to show, that they have not, risen above the correct storage temp to make them inactive. Anyway, that was my point.
Yeah, I totally understand, and we totally understand and relate to that as well. And we will work with those facilities on a one-on-one basis to, be as efficient and as effective, and really not hamstring them in their staffing models if that's going to be burdensome from them. But we'll firm up those details and get that going. But totally understand that, and we'll coordinate and work with those partners as appropriate to mitigate any of those issues. Dr. Roscoe, as far as speaking to the shipping containers, do you want to provide more information exactly about the temperature piece of that?
Sure. The Pfizer vaccine, I think, as we all know, needs to be maintained long-term at minus 80 degrees Celsius. And that can be maintained for a certain amount of time inside the shipping package that's provided by Pfizer, as well as an ultra-low if an ultra-low freezer is available. But once the vaccine comes out of that ultra-low environment, it can be maintained in a refrigerated or a regular freezer temperature capacity only for 5 days. And then once you thaw the vaccine in preparation for administering it, once the thawing process begins, you have 6 hours. So just knowing those 3 steps and those absolute hard cutoff time periods, I hope that you can see with trying to coordinate, for example, getting staff vaccinated at Adams County Health Center. Lincoln Council is going to come with a lot of logistical. But it's something that Ricky and I and the team continue to discuss on a daily, if not hourly basis, is how to, especially for some of the more outlying or farther from the major metro centers in District 3, how are we going to get this coordinated and make it happen? So all of our healthcare providers in District 3 who are operating in frontline capacity get access to the vaccine when they deserve to get access to the vaccine. I will also just of note, for example, St. Luke's health system plans to vaccinate the majority of their staff from central vaccination points. They're not planning to do a decentralized for the same challenges that I just described with maintaining appropriate cold chain and storage capacity, especially for the Pfizer vaccine.
I just had a question. I'm not worried about any of that stuff. I just wondered, out of curiosity, how many vaccines are coming to the entire state? Versus just the 2,000 that are coming to our district.
I can double check that. Ricky, do you know? Nope, you're on mute.
Just for the sake of giving the accurate number, let me pull back to those numbers that I have, and I will provide that to you here in a sec. But yes, just knowing that it was all divided out by Department of Health and Welfare through the Idaho Vaccine Advisory Committee, and I want to say, and Nikki may know more specifically on just the breakup, but population based is how they divided up the allocation of how much got to each district.
Thank you. I believe there, don't quote me on this because I don't have it in front of me, but I think there was between 30 and 40,000 doses that came to the state. And as Commissioner Ellie, okay, thank you, Commissioner Dale. So I think that it was dispersed, if I recall correctly, based on the Tier 1 group, so based on the disbursement of healthcare providers across the state.
Oh, Ricky, you were talking about the Moderna vaccines coming out next week. As that, they haven't been approved by the federal FDA, have they?
Not yet. We don't have an EUA on both, but the information that we were told that it is suspected to follow suit with a Pfizer EUA over that time frame, looking around on the weekend and then being able to have those doses come in next week. But no EUA has been authorized at this time.
And that's 3,900, you said?
That's the allocation that we've been told we're receiving from our region here, yes.
Okay, thank you.
Is there any other questions or comments on that for Ricky or Dr. Roscoe or Carol? If not, we will move on to the COVID-19 health alert level update. So, Nikki?
Thank you, Mr. Chairman, and I will give my time over to Rachel to kick us off on the update that we have on the health alert levels, and but happy to answer any questions that you have.
Hello. Thanks for having me today, everybody. So I'm just going to quickly go over the health alert levels as they stand currently, and then some of the trends we've seen throughout November. Currently, all 6 of our counties are in the red health alert level. So that means they all have above 5 daily new cases per 10,000 people in that county. And then we're also seeing very high positivity rates right now, averaging about 20% throughout our district. And typically, we are hoping to see those at 5% or lower. Our exposures right now are, mostly household and workplace exposure, which is to be expected. That's pretty consistent with what we're seeing across the state as well. And then we also are seeing some through social gatherings and community gatherings. We did have 30 cases that reported exposure from Thanksgiving celebrations this year, which I'm assuming that's fairly underrepresented, as most of our exposure data is not complete. A lot of people won't respond to those questions. Additionally, we have seen a spike in cases over the last month. So throughout November, we saw quite a spike in case counts. We were averaging about 9.2 daily new cases per 10,000 people in our district. And then the most recent data that we're actually looking at for this week for our health alert levels, we haven't published any of this yet. We haven't even had our meeting on determining the alert levels. But we're seeing about 8.2 daily new cases per 10,000 people in our district. So we are seeing a bit of a decline in case counts. I'm hoping we can keep that in a downward trend through the new year. But I am concerned that we're going to see a bit more cases coming from holiday celebrations and those 3-day weekends that we're going to be seeing coming up. So that's all I had to say for the health alert levels. There is one other thing that I wanted to touch on, and that is the number of COVID-related deaths that we've seen throughout November. You all have probably noticed that we've had quite a few new deaths reported in the past few weeks. Most of those are from the month of November. A lot of times our deaths will be delayed by a week or two. And that's just so that we can make sure that we're going back and checking everything, making sure that COVID-19 was a leading cause of death, making sure we have all the information from the death certificate and hospital records. And so for that, November was the deadliest month for COVID-19 in our district, with just under 70 people dying from COVID-19. And a few other mentionable things for that is the average age of those deaths was much higher than we've seen previously, at about 81 years old. And we're seeing a much smaller percentage of those individuals actually had pre-existing or underlying conditions. Typically, it's anywhere from 40 to 60%. And we're seeing from those November deaths, we saw about 25% of those individuals had a reported underlying condition. So if anyone has any questions, I'd be happy to take those, or maybe Nikki as well.
Rachel, I have a couple of comments to make. Thanks for that update. I just want to share with the board that talk a little bit about the positivity rate. I just want everyone to be aware that one of the challenges in Idaho, like many places in the United States, is we still don't have widely available and accessible testing. And that can affect some of the numbers that we're looking at. There is some additional information in positivity rates that pertain to Health District 3. I'm in almost weekly conversations with primary health, with the chief medical officer there, and the CEO. They're doing an awful lot of testing in Ada County as well as Canyon County. And I realize that's not all of Health District 3. But they've seen some decreased demand in testing over the last week, rather the last 4 weeks, but especially last week. That's for unknown reasons, but they're seeing very high test positivity rates. So in excess, combined across those two counties, above 27%. And when you break it down by county, actually the test positivity rate is much higher in Canyon County at 35%. These are tests performed by primary health. In comparison, that's holding steady and quite high. And in comparison, they're seeing a downward trend in the county, now close to around 20%. In addition, Southwest District Health is also performing testing. We're using the rapid antigen test, the Abbott product called Binax Now. And that's also a captive audience, so to speak, in that we are primarily testing teachers, occasionally students, as well as first responders and other essential staff, and essential employee cadres who notice symptoms and are quite motivated to get tested. And there are we've had multiple days where we've had test positivity rates here at the health department in excess of 40%. So a little extra additional data that I wanted to share with you.
Thank you. Did any of the board have any additional questions?
Okay, anyone on the board? It sounds like you have answered their questions or concerns, so thank you very much. I'll go back to Nikki.
Thank you, Commissioner Elliott. And I know that this agenda item is an action item. Again, just as a reminder to the board that the board's preference was to vote on approving this method, our metrics, and mitigation strategy recommendations to the public on a recurring basis. So that's on here. And then also, Ricky had texted me while Rachel was giving her update, and the state of Idaho is receiving 13,650 doses of vaccine in this first shipment. So that number is lower than what I said before, so I wanted to clarify that. And also just emphasize, too, that that is the first dose of a 2-dose series, and the well, whoever's holding that vaccine back is holding back the second dose that'll be coming in a few weeks.
Nikki, according to your information, and what my understanding is there 3 weeks between the doses? And so with that, you say they're holding back. So of those 2,000 doses, that will treat 1,000 people?
So the 2,000 doses that we're receiving this week will go to 2,000 people.
Okay.
And then in, I think it's 3 weeks from now, we'll receive the second dose shipment that will then be dispersed to that same group.
Thank you.
And I think the Moderna has a little bit of a longer period between the 2 doses.
That's correct, Nikki.
Do you have
The Pfizer vaccine.
assurances?
It's a two-dose series separated by 20 days. The Moderna is a two-dose series separated by 20 days. So 3 weeks and 4 weeks.
Dr. Roscoe said there's 3 weeks between the Pfizer vaccines and 4 weeks between the Moderna vaccines for the booster.
Is that similar technology to the shingles vaccine? It's a 2-dose. Is it similar sort of science following that? Or have to... Well, the new shingles vaccine is 2 doses.
Right. Commonly, Dr. Summers, commonly the first dose you'll get an immune response, but when you get a booster, it kind of puts it in cement into your body, and so you have a prolonged response. And that's what we've seen with COVID, is that some people seem to lose their immunity relatively quickly. And so hopefully by getting 2 doses, that will cement that and will be a longer lasting immunity.
Thank you. Is there anything else? Any other questions or comments?
Comment, please?
Yes, sir. Kelly, go ahead.
I just want to thank the staff at Southwest District Health for their professionalism and that by giving the test. I've been tested here twice, and both times it was done very well, and I give high regards to those that are working here and doing that and putting themselves out there to the public. I appreciate that immensely. And I know that, only reason I got tested is because I have to be around other people and have to have an obligation not to carry if in case I am positive. So I do test for that reason, is because I have to go to meetings. And I think that's the right thing to do, not to put anybody else at risk. So anyway, that's all I have. Thank you. And thank you for the district health staff.
Very good. Thank you. Are there any more comments? Commissioners? Nikki?
Mr. Chairman, I'm just waiting on the action item.
Well, I need to have it written down.
The way the board has been wording it is to, I think, a motion to approve the continued use of the health alert level system and metrics or something to that effect.
Okay. Well, it needs to properly cover what we're doing. So that's why a lot of times I like to see it written down to make sure we're not forgetting something in the actual approval or the motion.
Mr.
But
Chair,
if you can do it, go ahead.
Mr. Chair, I have had conversations with a number of people who are grateful for the growth of the updates and the health alert levels. It's sort of been evolving in how it's reported on, and several people have commented to me how they appreciate that. And I think I would be happy to make a motion that the Southwest District Health staff continue to use the health alert level system that they are doing.
Okay.
Dr. Summers, I'll second that.
Okay, does that cover properly, Nikki?
I believe so. I think that system's connected to the mitigation strategies that we've developed and the metrics that we use. So I think that's sufficient. Thank you.
Okay. In that case, then I have a motion and a second. All in favor of the continuation of that, say aye.
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 Those opposed? Okay. Motion carries. Be it noted, there is one nay. Okay, if there is nothing else, then we will take a few-minute break. I know. I'll start over. Introduction of new employees, Southwest District staff, whoever's doing that. Is that you, Nikki, or do you have someone else? Okay. Okay.
Hi, this is Jamie. Can you hear me okay?
We can hear you. We don't see you. There, maybe.
Okay, so I'm sharing a photo. This is my new staff member, Anthony Lee. Can you see him? He is new to us. He's an environmental health inspector. He's been with us for about a month, and he came from South Central District Health in District 5, and he's working in our septic program, and we're really excited to have him.
He looks happy to be there.
This is his badge photo. I don't think he knew we were going to be sharing it to the entire Board of Health.
Well, he's a happy, smart-looking guy. We're glad to have him.
Yes, he's been doing great.
Okay, who's next?
This is
Or do you
Carol.
only have one employee?
This is Carol, but I do not have any new employees.
Are you filled up, or are you still looking? Just don't have somebody for this week?
I'll have some news for you later in the agenda.
Very good. Are there any more? Yes.
This is Jamie again, and we have 4 additional COVID investigators, and I was going to show pictures, but I'm not sure if I can transition them all. But we have 4 new staff that have joined us on the COVID team, and I believe Ricky Bowman was going to do the introductions, but he looks like he stepped away. So we have a total of 5 new staff members.
Yeah, welcome them for us, I guess. We can't see them.
Hopefully we can have them come in person in the future.
You said most of those are investigators?
Yes, 4 of the 4 new COVID investigators.
Okay. Very good.
Oh, Ricky's back if you want to have him introduce them.
Sure.
Okay, Jamie, is that me?
Yeah, you're up, Ricky.
Okay, so I'm going to, let me see if I can pull up my screen here and just share some pictures of our new COVID staff. So can everyone hear me okay?
Yes.
Okay.
Yes, we can.
All right. So first we have Lisbeth Gutierrez. So can you see Lisbeth? Okay.
I'll leave my microphone on.
Okay, she is one of our new COVID-19 bilingual investigators. Comes to us with experiences working at clinics and interviewing, so she is a great fit for our team. Our next investigator that we have is Lupe Serrano. She's a recent graduate from BSU Health Science program, doing some interviewing experience with the infant toddler program. That skill set is very much transferable to the work she's doing for COVID. We have Ricky Fix. She is one of our new COVID bilingual investigators. And she also too comes with interviewing experiences, volunteering and working at this clinic. So, like I said, they're just coming in really hitting the ground running because of their previous experience, which was really helpful for us.
Okay. Ricky, can you speak a little louder or project your voice a little different? You're fading in and out, and we can hear you a lot of times, but some can't.
Can you hear me now better, Mr.
That's
Chair?
better, yes, sir.
Okay. And then our last new addition to our COVID team is Norberto Solorio. He is our COVID monitor, so he calls all of our patients and checks on symptoms, and especially those who are at high risk. And he comes with us with a plethora of customer service experience from previous jobs. That is our new COVID staff to bring on more and within the next couple weeks.
Okay, thank you. Is there anything else, Nikki, for new hires? Okay. Yes, go ahead. Okay, yes, should do that. I will echo Commissioner Aberstari's comment there. We need to definitely thank all the new staff for coming on in this tumultuous time. I'm sure it's very stressful for a lot of the folks that probably everybody that works here. Okay, on to our November 2020 expenditure and revenue report. So that's Troy.
Good morning, everyone.
Are you still in Hawaii?
I'm still in Hawaii. I'm remoting from Hawaii, but a magic clock keeps appearing above my head. I'm not sure why.
Okay, all right. Well, we go from one of the other people that had the Aurora Borealis.
Yes.
And you
yes.
know, I mean, it's 100% flip-flop there.
Right. Right. Oh, thank you, Mr. Chair, and good morning, commissioners. If you'll turn your attention to the expense report that's in your packet, you'll see kind of our report for this month. So just drawing your attention immediately to over to the far left, you'll see our cash balance from our fund balances from the beginning of the year, which is July 1st to November 30th. We've increased in our fund balances by approximately $500,000. So some of that, I just want to remind folks, and I wanted to draw that to your attention right away. Some of that is, a good chunk of that is monies that we received for our COVID response that we did early on, or kind of in that later part of the fiscal year 20, that we received reimbursement in fiscal year 21. And so just as if you'll remember that we ended fiscal year 21 in a negative cash impact, and so that receipt of those funds coming into fiscal year 21 kind of distorts the picture a little bit. I just wanted to remind folks of that change. And so when you're looking at the far right on the top, you'll see then our year-to-date cash position. You can see that our current cash position at this point for through November 30th is in the positive of $784,972, with a change for this month of $19,384. So you can see that some of the reimbursements that we've received have kind of helped to offset. The one thing I want to kind of let folks know, and this kind of goes to more of a like almost a COVID update as far as the financial side goes. We still have some reimbursements that we're requesting. We have some time in July, some time in October, and we're working on our November reimbursements now. But that time in July and in October is kind of, particularly the July area, we had kind of a gap in our subgrants. And so that time has not been billed. So you'll see that we're working with the CFAC funding, which is the CARES Act funding that comes directly from the governor. So we're working on getting some of that sent over there. So I'm working with our EOC groups to kind of help define where folks were working and what areas I can bill those to, just so you can see. So while I said that may not make full sense when we have this, $19,000 in positive cash position. What that really means is that the revenues that we've received from our normal operations have kind of kept us, since we've had those places of non-reimbursement, those places of reimbursements or revenues that we received from our normal daily activities outside of COVID have kind of kept that environment in the positive. So as those revenues may start to trail off until we get some of those revenues coming in from, say, from July and from October, we may see. So you may see next month, based on what we can do in December in our billings and receipts, that may whiplash a little back into the negative for the change number in January. So just to kind of let you know, I'm not sure that will happen depending on what we receive in revenues, and because we do have a lot of revenues coming in on the EH side for December, so that may actually not happen until February. So it's something we're watching. Our cash position is something that we try to keep an eye on. I know by the end of the fiscal year, we try to make sure that we're as close to cash neutral as possible. So we may have some further conversations later down the road when we determine where we stand with regards to our reimbursement requests and with regards to how we look in our reserves. So then,
Troy?
Yeah.
May I, does this only go through you have to bill all this by December 30th?
Correct.
Same as our counties have, or is this ongoing? Does it go past that time period? I'm not sure of the CARES Act money for you or for the district.
Yeah, Mr. Commissioner, that's a great question. I think you can share that. Is exactly how it works for us as well. We have through December 30th. So any activities that we incur through December 30th, we'll bill for. At that point, again, so how we've been working it is primarily our contact tracers, and that contact tracing effort has been kind of coded to that CFAC funding. So as that goes on, I submitted to the CFAC group on the 11th what we estimate we'll need from that CFAC funding through December 30th. So once we've gotten that, we've got those numbers hard secured, then we'll submit an actual reimbursement request. They'll give us a deadline as to when that request has to be done, but the actual end date, you are correct, it is 12/30. So that in January, we'll need to start having conversations about where to code our contact tracers outside of, since they won't be covered by the CFAC anymore. My hope is, and I don't know that this is really a thing, but my hope is that
yes, go ahead.
There will be.
I had a question from Commissioner Eversbury.
Oh yes, I'm sorry.
Go ahead, Kelly.
Yeah, Troy. My question is, we had the funding in place to keep us in the black, but how much is owed in the month of July and then November? Are we looking at having go back into the budget if we get this money on the CARES Act?
So I want to make sure I understand your question. Are you asking if we didn't get reimbursed for those funds, how much would that dip into our funds? Is that correct? I can't hear.
I'm asking how much have we already spent out of our budget that needs to be reimbursed from the CARES Act or can be reimbursed from the CARES Act?
Oh, gotcha. All right. Yeah, so at this point, and I don't have that number in front of me, but I believe what I submitted to the committee on the 11th was about 500, a little over 500,000 is what we requested from them. So that is our CARES Act. So we have not submitted any requests to them. So that's going to be our total request once we have determined who can live in that funding, and then we'll make that request. But it is a little over 500,000 is what we determined we would need specific to the CFAC funding. Did that answer your question?
Yes. Did that answer your question, sir? Yeah, if we don't get paid, yeah, no, definitely. My other thought is, what do we do past January?
Yeah.
I don't know that, did we put that in the budget to be able to do that for the rest of this year? I see you shaking your head up and down. Now I see it sideways. I mean, how are we going to keep up with the contact tracing and the testing and everything that goes on unless there's more money that comes in? I mean, we just don't have it in our budget to continue with that. So what's the plan, I guess?
Well, Mr. Chair, I think I heard yesterday at a Treasure Valley Partnership meeting that there was movement on the national congressional level, and they're hoping to have something come out that would carry us through at least till February, and then perhaps beyond. So hopefully that's on its way.
Yes.
Yeah, I'm saying if we don't have, we'll have supposedly vaccines available to the general public, but not till May or June. And then the question is, how many of those folks are actually going to take that? From things that I've read, it's how many? 61% would. That's higher than the last I heard, which was 54. And then it depended also on the ethnicity group. A lot of the other groups are much less than that who are willing to take that. So, I mean, how long do we need to plan for, and what kind of dollars are we going to need? Because, I mean, we do have other things that we need to take care of, you know, to serve our population and you know, take care of other safety and health concerns.
Well, Mr. Chair, it just occurs to me that at some point, the extensive contact tracing we've been doing will become sort of not necessary, because we know people are going to get it, and the vaccine will be available. We can't indefinitely keep trying to trace every person who gets this disease. You just can't do that. And so at some point, this program will have to end. And I would assume that would be at some point in the summer, perhaps when the majority of
I think it'd be later in the summer if at that point. But I don't know. At some point, I guess we either reach a herd immunity or we don't. But either naturally or with vaccines. It has to occur basically naturally with the help of vaccines, I'm sure. Yes, Nikki.
Thank you, Mr. Chair. Just to maybe address a couple of the questions that are being thrown out there. We do anticipate, and I'm hoping sooner rather than later, that we will, just like we did before, I think it was around September, like right around the time school started, we were a lot less busy than we are right now, and we were able to scale down. And, you know, right now we're having to scale up a little bit, but I anticipate that we will scale down. And I don't know that COVID will maybe ever go away, just because it will probably be on our reportable disease listing, and we'll investigate it like any other disease. But I would think that definitely will come to a time where we can just absorb that work like we do all the other reportable diseases that we monitor. It'll be interesting, I guess. No one can really probably predict on when that will happen or from where we are today. In regards to the budget, and I'm not sure that Troy mentioned this too, but we also have other federal subgrants that we're receiving through the Department of Health and Welfare, some pretty broad in their scope, with supporting the response, specifically probably more towards the investigators, contact tracing pieces. Contact tracing is right now kind of on the back burner for the district, because we have just too many cases and not enough staff to stay on top of it. And then we also have some subgrants that help support testing, particularly for schools, but other priority groups. And I think we have or will have a subgrant for a vaccination to help support vaccination rollout. So I think I'll pass it back to Troy if there aren't any other questions. Yes, Commissioner Abster, yep. To your point, yes, we do have other funds coming in to help offset costs, and Troy has done an excellent job working with our partners at the Idaho Office of Emergency Management if we need to pursue FEMA reimbursement as well. But that's, yes, exactly, last resort.
Go ahead, Troy. I'm sorry we interrupted so much. But,
no, this is a great conversation. Thank you, Commissioners. I appreciate it.
Inquiring minds want to know.
They want to know it's true. No, and I want to echo. Thank you, Nikki. That is really a great point. I think that really does go to the heart of really where we might be heading, specifically after 12/30. We do have kind of a range of sub-grants that we will typically probably lean on until some other resources make themselves available, like Nikki had mentioned. There may be some sub-grants for vaccines. We did just receive some amendments to the sub-grants in the preparedness area to provide more funding specific to contact tracing, and the language in those sub-grants are very broad and cover a good chunk of our response. So we can lean on those in the short interim. However, those sub-grants are quite long and they go out for a long distance. So if we burn through all those funds before the activities are done, we need to find another way to get those activities done. So that's something we want to be really sensitive about when we're leaning on those grants. But I think in the short term, we're able to kind of keep that process going through some of the language in those sub-grants. My hope is, and I had heard that as well, Commissioner Dale, that there was some conversation about extending or creating another means for funding, either through the CARES Act or something along like it. So my hope is that they will just extend that period and then we can continue using that as a source of funding. But I have not heard anything official as of yet. All right, if there's any other questions, I'll just keep going, and feel free to jump in if you have any questions. You can see from the report itself that our revenues are definitely up, and again, that's really very driven by COVID. So our COVID reimbursements are definitely up, and you can see on the second line of the revenue area, we're at 66%. We should be at 41.7%. So you can see that a good chunk of that really comes through in our environmental health, and we have our clinic services. So environmental health is where our COVID response lives. And so you can see that environmental health and the clinics really have been providing some good revenue support. So that's in regards to our contractual activities. So again, that's at 66%. Our overall revenues are at 51.8%. Again, we have some that are in the lower range. Our interest is a little bit lower than we had anticipated in our original budget, and that is due to primarily the feds and the interest rates that are associated in our investments. So that's very tied to that. So that will probably be definitely an area where we won't reach our revenue expectations. And then our other committed funds are only at 4% at 919. So those were what we had in the budget. So if you look on the next page, you can see essentially a graph that represents those numbers, and you can see in our district funds we've been kind of staying static, but you can see in our fees how they've kind of gone from October to November. Our fee revenue is about the same as it was. You can see the contracts. The reason in October, we had a lot of billing going on in October, not quite as much in November, and you can see that actually in the numbers. And for our revenue, for our net revenues for October were 863, our net expenditures were 843, leaving the 19,000. So you can definitely see that there was a little bit of a decrease from October to November. And then if you look at our expenditures, you kind of see something very similar. In this case, we had essentially a little bit less in personnel than we did in September. And remember that October is a 3 pay period month, so that's why that one's a little higher. And you can see a little bit of a decrease. We had some vacancies in personnel that we were working to fill. But you can also see that our operating expenditures went up between October and November. So even though revenues were down, expenditures were up a little bit, which kind of created that really close environment with our cash position. The third chart is, again, where our investments land. And you can see, kind of as we talked before, this is the trend, the distribution yield of our interest rate. And then you can also see as that trend happens, so does the dollars that we actually receive. And again, part of and we talked a little bit about this last time, the reason there's a little bit of a disconnect between that blue line and that regular line is in the prior months, July through September, you can see those are really close to that distribution line. But for October and November, there was a little bit of a drop. And that was primarily because in order to get some of these expenditures done, I needed to pull from the LGIP account, and essentially that's where this drives. And so then once we get reimbursements, I toss it back in there. So that little bit of a disconnect can cause a decrease in our yield. So outside of that, it's not a huge difference, but that is the nature of that disconnect. I think that's the end of my report, unless anybody had some additional questions or thoughts I can act on.
Any questions or comments, commissioners? Doctor, anything? I just throw you in the bunch with commissioners. I'm sorry, sometimes I don't acknowledge you separately.
Sorry.
Okay. All right, I guess that's what we have, is a thank you from the board, so thank you, Troy.
Right.
And I would just say, Troy, you need to figure out how to get that SWAC up in the sky there on that.
I know, the one that's on my head.
Yeah, it's right on your head sometimes.
Yeah, I tried to kind of scooch it out of the picture, but it's definitely there.
All right.
Thank you, Commissioner.
Okay. Let's see. No, we've already passed that, so we can go. Now we're on to the approval of the 2021 Board of Health meeting schedule. Back to Nikki.
Thank you, Mr. Chair. In your binders, you have a copy of the public meeting notice for our 2021 Board of Health meetings. If you can review that and approve it if you all agree, or if there's changes, which seems like often there are, but Katrina did go through and check holidays, and we looked for the IC agenda, but we're not able to, and some of their conference dates weren't out yet. We usually try to not conflict with them.
Okay. Yeah.
All the meetings are virtual.
Yeah. Even some that they had planned in person, they've changed and they had to change to virtual. Commissioner Purdy, is March all right to go back to the 9 o'clock, or would you prefer to stay with the 10 o'clock for your possible winter driving? I know, but I'm just wondering if March is a little early to cancel that winter driving. That's all. If that would help you, I don't see a problem with that unless there's anything else from the board.
Mr. Purdy, can you turn your microphone on? Sorry, they can't hear you at all. We're trying to make sure it's audible.
Okay.
10 o'clock is pretty nice, because then I can drive down in the morning.
Okay,
so
very good.
That one day,
Well, we want you to get here safe and sound. So if that will help, I would recommend that we also have the March meeting at 10 o'clock.
Okay, thank you.
Any other comments on that or suggestions? Our faraway remote folks, do you have that in front of you? Or would you like that to be read so that you know when those days are?
Mr. Chairman, could you read it? I didn't get a copy of that.
Okay.
So Mr. Chair, could I ask a question on
Yes, go ahead.
March 16th and May 18th are anomalies in the number of the Tuesdays. Is there a reason for those? Why they're not like, most of them are like the last Tuesday, but...
Well, it would be March 23rd. I'm not sure what's there. Normally, we change to the 3rd if the 4th is, I don't know, close, either on a holiday or, I don't know, is that spring break?
Yeah, Commissioner Dale, Katrina's texting me as she's listening. Spring break and Memorial Day.
Okay, very good. Does that answer your questions then?
Perfect.
Okay, I will go ahead and read those for you then, Nate. So everything is on Tuesday. On January 26th, 2021, the meeting would be at 10 o'clock to allow for winter driving. On February 23rd, 2021, also at 10 o'clock. March 16th, 2021, also at 10 o'clock. At April 27th, we go back to the 9 o'clock schedule.
May 18th, 9 o'clock. Tuesday, June 22nd, 2021, also 9. July 27th, 2021, 9 o'clock. The 24th of August, 2021, 9 o'clock. September 28th, 2021, 9 o'clock. October 26th, 2021, 9 o'clock. Tuesday, November 16th, 2021, shown at 9 o'clock. Again, I'd go back to Commissioner Purdy, and perhaps also for you, Nate, would 10 o'clock be better in November?
I would think 10 o'clock would be better.
Okay, is that, I mean, we do get some snow pretty good by right around Thanksgiving time, and especially in the higher elevations. Yeah, we do have December marked at 10, but I don't have a problem with going back to 10 o'clock in November if that helps, and especially with the safety for you folks. Okay. What are you thinking on that, Nate? Would you prefer 10 o'clock on November 16th? Well, maybe we did lose him. Okay, and so Commissioner Purdy, you're okay with that at 9 o'clock? Okay, so we'll leave that at 9 o'clock. So November 16th, 2021 at 9 o'clock, December 14th, 2021 at 10 o'clock. Okay, if that is the case, that is the only change I see is going to 10 o'clock in March, on our March 16th meeting. If everyone is in agreement with that, I would stand for a motion to accept the meetings with that change. Okay, I have a motion, to have a second.
This is Commissioner Hannigan, and I would approve that amended schedule.
Okay, very good. Would you second that? Commissioner Purdy beat you to it.
I would second it.
Very good. We have a motion and a second then. All in favor say aye. Aye.
Aye.
Aye.
Okay. I think everybody said aye, so we're good. Motion carries. Thank you. Okay, on to clinic operations update. Does that go to Dr. Roscoe or to Carol?
I think it'll be both.
Okay. Whoever wishes to start, go ahead.
So I'll go ahead and start. I had some, is it echoing over there, or is it just me?
Oh, it's probably...
You can hear me okay?
Yes, you sound great now, Carol. Thank you.
Okay, thank you. First thing I wanted to do is thank the board members for their service. I heard a lot of thank yous to our employees today, and I'm a Southwest District employee, and I appreciate your service. Thank you very much for all you've done. This has been huge. I wanted to provide a staffing update for clinic services. And you may remember that we were starting a venture in Marsing School District, and we have a school nurse out there, and the community hub site in Marsing. And we now have a volunteer pediatric nurse practitioner that works full-time at BSU, and this will be providing for clinicals for this nurse practitioner. And he has an interest in Marsing School District and helping out in that area. So the first part of January is our plan for this new venture of a school site and healthcare. So I think that's going to be really exciting to move forward on. And then we have 2 new nurse practitioners. Both of them will be part-time that accepted offers just yesterday, and they will each work between 8 and 12 hours per week. starting the 1st of January. And they will join with our 1-day-a-week nurse practitioner. And these two are the start of a replacement of our nurse practitioner that left not too long ago. She was at 32 hours a week. So we're starting off slower, moving forward on our volume, do our marketing, and help provide in our outer clinics, and also towards our continued vision of providing school site healthcare and mobile clinics. And I'll introduce the nurse practitioners next month. And just a side note, each of them have unique skills. We have one that has been a nurse practitioner for 22 years in Washington, and she has a variety of services she can provide, including Medicare wellness exams. And she's new to public health, and she's excited to work with our population. And the other one is a new nurse practitioner graduate, but she's been a nurse for, I'm thinking at least 15 years. I can't remember the number. And she has been a school nurse previous and very excited to work with our public health population. So we are really looking forward to moving forward in all these new ventures in January. And that's my part. Dr. Roscoe?
Also excited to have these two nurse practitioners come on board, working part-time and assisting with the clinical services division. Other than that, we're very close to getting a research determination and a green light to start conducting a validation study, evaluating our rapid diagnostic test that's being used actually all over the state. But Southwest District Health is the health district that's going to perform this test analysis, comparing it to the gold standard of PCR, which of course we'll share with the entire state. This is a collaborative effort between our Southwest District Health and the state lab, as well as IDH. And we are underway with the demonstration project for wastewater analysis in school settings. Primarily, we're comparing wastewater analysis to the ongoing testing efforts at NMU, in Nampa, and as well, we will be including some wastewater analysis testing for a school in District 3 as well. So they've started collecting samples, and I just got an update yesterday that they have begun the actual analysis, the PCR testing of these samples. This will continue for about 3 months. And the goal of this activity is to determine if wastewater analysis is a useful way for monitoring COVID in school populations. So expect more information and updates on both of those activities at future meetings.
Okay, is that the end of your report, sir?
Yeah, end of report, apologies.
Okay, I'm just checking. I didn't want to cut you off or you know, have a technical glitch and we weren't listening. Okay, well, thank you very much. Yes, go ahead, Vicki.
I asked who's paying for this.
I can answer that question.
Okay.
I don't know
Okay.
if I heard you. Yeah.
Go ahead.
So in regards to who's paying for the testing, that's being covered by our federal pass-through funds, sub-grant funds.
Okay. Are those available for any other use or only for that use?
The sub-grant that we have for testing is pretty, well, I don't want to say it's broad, but it covers testing of population priority groups. That's what we're using right now for like our first responders, long-term care facilities and schools, if they want to be tested for like, they can come in and get a rapid test here, so, that is what those funds are for. Does that
Okay.
answer your question?
Well, yeah, I guess partly. My other question would be, so if they find out that it's doable to test and have that mean something, so if the school, yeah, what are you going to do about it? I mean, if the school tests positive, they show up one positive test. I mean, does every kid in the school get tested, or what does it actually mean?
Right. So
You know, what's the end result that actually should be beneficial for the money?
Yep. And I'm sure Dr. Roscoe's question too, but my understanding is that it's a good early indicator. You may not have people symptomatic yet, especially a younger population, so they could use that as kind of an early detector, per se, of a potential problem on the horizon that they might want to get ahead of. So, Dr. Roscoe, is that how you would frame the value of the wastewater testing?
How would you get ahead of it? That's what I'm trying to figure out. So what, I mean, you know, if the kids have COVID, I understand that, you know, if the test is reliable, but then, so what do you do about it? I mean, again, I'm asking, does every kid now, because you know you have COVID there, does every child get tested? Is it a mandate for a vaccine? I mean, what are they using the information for that is useful on a long-term basis, or at least, you know, I don't know, to seem worthwhile. Sometimes there's tons and tons of testing, but I don't understand what it does, I guess.
So wastewater analysis serves two functions. Early detection, including in individuals who may be asymptomatic, as well as ongoing surveillance. So with the early detection, that would be in a population that's not known to have COVID, and you identify COVID in the wastewater that's being shed by that population, a public school or a college campus population. And that would then trigger further evaluation of that population with individual testing. Also, we're evaluating school and you don't see, you're not detecting the virus, then that is one that can be monitored with wastewater versus going testing everyone, and just to be on the safe side, with you know, more expensive and staff-intensive individual testing efforts. You know, COVID is so widespread in Idaho and the United States in general that most of the wastewater analysis happening now is for ongoing surveillance. And so if you have a school or another population that's had some cases, and then you have instituted some mitigation measures, you would expect to see the level of the virus in the water that's associated with that population. You would expect to see the level stay stable or start to go down. And so you can confirm that as well. If you're seeing a downward trend and then an upward trend again, that would alert you to the fact that there may be new reintroduction of coronavirus into that population. The ultimate point is to increase testing capacity or identification capacity without always having to rely on individual testing, one test per one individual.
So I mean, again, if I go back to if you're using it for a school, and you see the test, does that mean they're shutting the school down, or I mean, how do you actually use that to be viable or beneficial? I guess, I mean, all of us, if you see that, then it goes to a mask mandate for the school, or I guess I'm just not quite seeing what you do with the information. I mean, you know, if the information's good, I understand that, but I just don't see what you do with the information at this present, at least the way I've heard it Maybe I'm just obtuse this morning.
Wastewater analysis is simply a tool. It's a tool to that allows potentially to monitor the level of coronavirus in a population. Not affiliated with any sort of mask mandate or shutting, a mandate to shut down the school. It's a tool that allows you to detect, often early detect, presence of coronavirus that's coming from a population. And from there, then you can make public health decisions to further evaluate. You have a problem, and how are we going to look closely to identify individual cases. And once we identify those cases, then we can do something about, start to talk about mitigation measures, obviously identify not only the case, but contacts and all efforts to reduce transmission in that population.
Mr. Chairman, just a quick question, and Dr. Roscoe, please just make this a real brief answer. We'll run out of time here, and I do have a tight timeline that I got to get back to the county courthouse for a meeting. I understood earlier on that I thought I heard that NNU, Norfolk Southern University, was doing some of this wastewater testing. Is that still going on, and do we have any kind of results from that if it did go on? Correct me if I'm wrong on that, but is there anything coming out of that?
Yeah, so that's the main partner that we're working with is NNU. NNU is also doing a very innovative pooled testing approach using saliva samples with their student population. This has allowed them to remain open with the exception of 1 week for the entire semester that they just wrapped up. They were very interested to compare their pooled saliva testing with wastewater analysis. They had a delay in primers for the PCR testing for the wastewater analysis, but they had been collecting samples on a weekly basis now for some time, and they've just now received the PCR primers and are starting testing on the wastewater samples. So we have no information available yet, but expect to start seeing some data, and once we see that and there's some preliminary analysis, then that'll be shared.
All right, thank you, appreciate that.
You're welcome.
Any other questions for Dr. Roscoe? Hearing none, thank you very much, Carol and Dr. Roscoe. We will go on to the director's report then, and Nikki, it is you.
Thank you, Mr. Chair. I'll go through these quick, knowing that we have a quite tight timeline. I'll also ask Dr. Roscoe if he could maybe just type up what he said, because I know it was hard for us to hear it here in the room, and I can share that out with you later on, just kind of a summary of his comments. For the director's report on the audit update, I just wanted to let you know that our audit should be wrapping up soon, and we should have a report. It sounds like we're on target to get that by the end of the calendar year. And as a reminder, the Legislative Council and LSO, the Legislative Services Office, have asked for a copy of that before the end of the year, in part because when we make our requests for state appropriation, there's a review typically of our audit reports of all the public health districts. And budget revision, Troy and I had mentioned to the board in a previous meeting, I don't remember which one, about the potential need to do a budget revision this year with all of the crazy funding things we've had going on with COVID. We don't think we'll need to do a budget revision, but that we'll probably need to come back and ask for expanded spending authority because of the additional COVID subgrants that we're continuing to receive. If the board would like to have more discussion about that, I'm happy to put that on the agenda for next month. And then I also wanted to make you aware that the CEC plan, which is the Change in Employee Compensation Plan that the Department of Human Resources puts out each year, was published. It's in your director's report tab. It's actually a pretty lengthy document. I think it's well over 100 pages. I just took their recommendations out of the document. This is often what we use as a starting point for our budget process when it comes to employee pay and benefits. And so this year, for this coming fiscal year, the Department of Human Resources, DHR, is recommending to the governor a 2% increase in the salary structure. They're recommending continuing that with job classifications that are currently on pay line exception to address specific recruitment and retention issues. A lot of those are focused on healthcare, as it's the public sector cannot compete with the private sector on healthcare provider wages. So, there is also a recommendation for a 2% salary increase to employees, and that there be basically the benefit package remain the same for benefits and the percentage contributions for employee benefits. So I went over that really quickly. Obviously, we can talk about that as well at future meetings, and this is, again, just a recommendation from DHR that goes to the governor that he considers in his budget recommendations to the legislature that include our state appropriation aspect of that budget. So that was quick, but I wanted to give us time for the executive session as well.
When did they give that to the governor?
So I think that when we get it is when the governor gets it, and we typically, we've already submitted our state budget, the districts have, and I want to say it's in early January that we know what the governor's recommendation is going to be in terms of the impact to the public health districts. I don't know, I'm guessing Troy's still on and he could correct me if I'm wrong, but I think that sounds right. I think our budget or our JFAC presentation isn't until February. Right. Yep.
Okay, that sounds right to me. All right. Thank you very much for a short, concise, and comprehensive update. Okay, we will then need to go into executive session. So how does that work with our moderator? Does she just shut off everybody else?
Yep, so everybody who's joined by Zoom to participate in the meeting will leave the meeting or will be kicked out by Ashley or Katrina, depending on who has the rights. Commissioner Marvin and Commissioner Hannigan will stay